I really want to give, first of all, before I start and hook up my computer, a round of applause to Patrice and her team, and Eric and both Erics and actually three Erics, for a great meeting. Patrice has been doing this. I've known Patrice for, I think, almost 20 years, and believe it or not, I think one of our first meetings in Philly was in a bar at the Irish Pub. And not a joke, where we just got some patients together, and actually she got the patients together, and it kind of grew from there. So really, kudos to her. So let me put this up here and we can get started. So what I'm going to be talking about this morning is the decision tree in treating Chiari. And there's a couple caveats to this. And one of the main ones is in my disclosures. I'm biased. Everybody, every physician, every person, every patient, we're all biased. We're all biased by our experiences. We're all biased by our backgrounds, our thought processes, and all these things. So you have to keep that in mind. And a lot of the things that I'm going to talk about are really just that, my experience. Maybe not right, maybe not wrong. I've been doing this for about 20 years now. And I became a Chiari surgeon kind of in a circuitous fashion. I'm a vascular neurosurgeon. I treat aneurysms in the brain, and I do endovascular treatments for vascular disease, stroke, AVMs, aneurysms. And it was actually almost to the day 20 years ago when I was new faculty at Thomas Jefferson. One of the younger faculty came up to me and said, "Hey, Erol, it seems like you really enjoy doing the Chiaris, during your residency, and you had some good outcomes. You want to be the Chiari guy?" So I'm like thinking, yeah, wow, this is great. I got a promotion already. It's like my first week there. It's like mid-July. And I kind of got this slap on the back, like, all right, and walked away. I kind of felt like I bought something there. And really what it came down to is, a lot of the surgeons like doing the surgery. It's a great surgery. It's beautiful anatomy. Many patients do well, but some patients don't do so well. And there's a lot of patients that don't need surgery, but they need guidance and they need help. And I think that was what I learned really early on, was a lot of this practice that came to me were people that had surgery that were still having problems, patients that were being followed, that they were kind of on the fence of, do you need surgery, do you not need surgery? So there's a lot that goes in, I think and I think most of the surgeons would agree, in the office than in the operating room, of really spending time with patients, of trying to dissect out, what the problem is, because surgery is not reversible, and it's one of the things I'm going to talk about, and that's really the basis of what my talk is this morning, is that decision tree of how to treat a patient and who to commit to surgery or recommend surgery to. All people who suffer from Chiari experience varied symptoms, and the key here is patients that suffer from Chiari, i.e., is the Chiari the cause of what your symptoms are? And that to me is the very, very first and most important step of making any decision. Really, who to offer surgery to, who to follow, and who to keep an eye on. And we have to put in context, it's very different than following somebody who has a mass in their brain that may be a malignant cancer that 3 months from now can be something much different. So it is okay to follow, as long as you're doing it closely, Chiari patients and not jump right into surgery. And I think one of the most important things that I personally learned over the years is who to help, and not just say, well, I'm the surgeon, you don't need surgery, go find somebody else, of kind of helping be that quarterback to, if you're going to treat the disease, you have to treat the patient. You can't just say, I'm a Chiari surgeon and I just do the surgery and that's it. You really have to treat the patient from a holistic standpoint, and that means getting them to the right pain physician, helping them sort things through. Now, I can't be the doctor for all those things because that's not my background, that's not my expertise, but it is my job to help get those patients the right care, and to make sure that that's being followed through with, really more on the physician end. And patient selection. That's, I think, every one of the my esteemed colleagues here, and everyone in this room is very lucky to have the panel that is here. You have world experts in Chiari, and I would tell you to kind of pick their brains during the time you're here. But patient selection is the key. Picking the right patient for the right treatment. And these are some thoughts that over the years that have, and they're just mine. They're maybe not right, maybe not wrong, but they're my thoughts. Adult and pediatric Chiari is not the same. It's a very different process. The symptoms are different. The surgery is different. So I do both pediatrics and adults, far more adult than I do pediatric. But I can tell you that the surgery there's a lot of confusion among patients because the techniques are a little bit different too. One size does not fit all. Age is not a limitation. Last week I operated on a 76-year-old woman with a Chiari, which is, she was just misdiagnosed for a really, really, really long time and ended up with a diagnosis of Parkinson's. She had a really severe Chiari. So, this idea that once you hit a certain age that, a Chiari surgery is not an option is not true. Every case is unique, and I think everybody in this room would agree with that. An important thing that to keep in mind, and it will follow with the rest of my talk, is that all the Chiari used to be an orphan disease. It used to be considered an orphan disease, meaning it's really rare. It's not that rare. And with the MRIs now, you can't go to a doctor for a hangnail without getting an MRI of your whole body. MRIs are the equivalent of what X-ray and CAT scan were years ago. 1% of every MRI performed has an incidental Chiari. Now, you can pay, for the doctors in the room, we can pick those numbers. Is it ectopia or low-lying cerebellar tonsils? But you get the picture. There's a lot of incidental Chiaris out there. That becomes a dangerous thing too, because that incident, you have migraines and you go and get an MRI, and the radiologist is diagnosed as a Chiari, you may get a surgery you don't need. So it's really important to keep that in context, that it's a lot more common than we thought. So I want to go through a couple of real patients, and I think that helps illustrate really the best, rather than me just showing you a bunch of slides and pictures. And I promise I'm not going to go too much into surgery because you have some great speakers that are going to talk about that. I have one picture and it's black and white because I knew everyone would be eating breakfast, so there's not going to be any gory, bloody pictures. So JS is a 25-year-old female, was referred to me because she had really severe neck pain. Just complete lack of energy. She couldn't get up out of bed in the morning to go to work, and had debilitating headaches that were worse around her period. So I saw her. This is her MRI, and this was diagnosed as a Chiari. And I think a lot of the docs in the room would agree this is probably more ectopia or low-lying cerebellar tonsils, but the diagnosis radiographically was Chiari. So what's important here? Well, I'm not even focused on this, to be honest with you. And first of all, I really don't read a lot of the reports. I do just because I know the patients are reading them, so I can answer a question if there's something in there. Because, we get MS, we get this, you had a stroke. You have to keep in mind, radiologists read what they see. And sometimes they read things that they don't see, and vice versa. But so what's the important thing is the office visit, sitting down with the patient, listening to them, talking about what their symptoms are. So turns out she's in a very high-stress job. She just started a position about 6 months ago, which is just very stressful for her. It was very stressful for her. She wasn't sleeping well for this whole time. Her neck, she's talking about her neck pain. So when I touched the back of her neck, it was literally sore to me touching it. Turning her neck, she could barely turn it. She had on review of her symptoms, she had a history of childhood migraines. She suffered as a child and in her teenage years, and then they went away in college. She had severe light sensitivity, loud noises bothered her. The way she treated, she went into a dark room, shut the curtains, and basically that's what would help more than anything. So on her physical exam, she had normal strength. She had great strength. Her sensory exam was completely normal. Her walking, her balance, turning around, all the tests we do for gait were completely normal. The only thing that wasn't normal was her reflexes were a little bit brisk. Now let's put that in context, because if you go online and you see, hyperreflexia and really brisk reflexes when we use our hammer, well, that's normal in a young female. As long as they're symmetric, that's a very normal finding. And you have to understand that those things, not everything is abnormal. So putting all these things together, the last thing that this woman needs is surgery. Because first of all, I can make that MRI maybe look a little bit better after surgery. It's not going to do anything for her symptoms. Because her symptoms, especially after spending time and listening, were completely unrelated. So the plan was, as I was saying before, is to kind of help quarterback this. So clearly stress was a huge part of her problem, and particularly the lack of sleeping. Whenever I can palpate somebody's, that's muscle. That's not a Chiari type pain. That's not a nerve type pain. When your neck is really sore like this, for the most part, and you can palpate it, that's a muscle pain. That's not coming from the brain itself. It's coming from some stress on the muscles. So the plan was I had her seen at our headache center. Her migraines were completely taken care of with that. They basically just started her on Maxalt, and when they started coming on, she took the Maxalt, and that did the trick. It also turned out that her sleeping habits were horrible. She was sleeping 2-3 hours a day, couldn't function throughout the day, and she got an orthopedic pillow, and when I saw her 3 months later, her neck pain was gone. So the bottom line is she was a lot more relieved, and it becomes this vicious cycle of somebody telling you need surgery, and all this stuff kind of happens overnight. So, not every Chiari, not every diagnosis of Chiari needs to be treated, and this is a perfect example of that. What's also very important from a decision standpoint is not getting too caught up in the films, because you can have some horrific looking MRIs and you don't even understand how patients can walk, and you see them and they're fine, and vice versa. You can see some very mild looking Chiaris on MRI and they have very severe symptoms. This is an MRI depicting it. It's important to distinguish that let me see if I have this is an upright MRI where a patient's sitting, and you can see the tonsils way down here. And then this is when the patient's lying down supine. You can see that there's a change in positioning of the cerebellar tonsils based on how we are positioned. Whether we're sitting, we're lying, the pressure in our head, our blood pressure, lots of different things will distinguish this. So it's important to put that in mind. Now, there's some great tools that, for some of you may have had before called MRI Cine Flow, and this is something Toshiba has recently come up with, and this is a really great dynamic. So that white that you're seeing going back and forth is cerebral spinal fluid. And this is a really important study because what we do for Chiari surgery is basically open this area up so that flow is no longer obstructed, to open up that area at the opening of the brain, the foramen magnum. And if there's free flow there's not a lot, for the most part, we're going to do with surgery. So there are some caveats to that, but that's an important study. All these things go into play of distinguishing who's going to be a good surgical candidate and who's not. So let's go to another patient. So this is Heather. She's a 42-year-old female. She originally presented to her primary care doctor with mild headaches that were new for her. She never, ever had headaches, and she was complaining more and more of headaches. And then she started dropping some objects, and her husband basically, really kind of pushed the issue and said, listen, you need to start telling your doctor some of these symptoms. So he ordered an MRI. And when I saw her in the office, she was somebody who's like, I'm fine. She's a mother of 3 doing, like a lot of moms of 3, doing 50 million things, had 7 different hats on. She didn't have time to be sick and was kind of denying a lot of her symptoms. Now, this is her MRI. Here's her cerebellar tonsils way down here. You can see them flattened out all the way down where they should be up here. Now, again, not all that excited. As a matter of fact, she looked a lot better than this MRI. This is a pretty severe Chiari, and her symptoms actually were real, but not as severe as you'd think. So on further questioning, she did have some ringing in her ear. She had difficulty swallowing, and she was actually with her friend with her, and she was denying everything, and her friend was like, come on, will you tell him the truth? Because she was with her a lot. She's like, look, we were just out to lunch, and you were like, you had 3 glasses of water because you were coughing through everything. Headaches were worse when lifting, when bending, coughing, laughing, sneezing. She didn't tell her primary care doctor that. It was just, well, I'm getting new headaches that, I never really got before. On exam, she could barely squeeze my hands. I don't know how she was picking up anything. The things she was dropping were coffee mugs, her cell phone, things like that. She had a decreased gag reflex. She was very ataxic. And what she had, which was very interesting, it was the first time I've ever seen this, was she had a truncal ataxia, something we call titubation, where her body from the center, we think of tremors like this, but her central core of her body was tremulous, and that's part of the brain called the vermis, which is usually responsible for that. So, her plan was surgery, because of her symptomatology, because of her MRI findings. And it was actually very interesting because we had her scheduled for surgery, and she came into the emergency room because the and I was trying to find the video because one of our fellows took a video of it. Her whole body was like this, and they thought she was being actually treated for seizures, and I'd seen her, in the office. I knew what this was, and I'd never seen anything like that before, and I'm curious if any other physicians were. So we did a semi-urgent surgery on her, and if you remember, this is what this looked like. And really the goal of the surgery is opening up the foramen magnum here, and you can see the cerebrospinal fluid is now free and open, and she did quite well. So it's important to keep in mind the overall constellation of symptoms with Chiari. Chiari comes with a lot of other things, and we're talking specifically about the adult form here. Hydrocephalus, herniation of the cerebellar tonsils, and then syrinx. So how are all these things related? Now, yes, they are all related. How are they all specifically related? Well, you can get a lot of different answers, and I guarantee if we had a panel up here, every doctor, some people would agree on some things, or maybe everybody would agree on certain things, but there certainly would be dissent. And what that means is that we don't really fully understand. But the current I think my thought process anyway is I always check for hydrocephalus. It's very, very important. You can't just focus on this down here because if there's hydrocephalus, oftentimes that's the cause of the Chiari from a downward pressure. As this cavity fills with fluid, the pressure increases here, pushes down, cerebellar tonsils block the foramen magnum. The syrinx is a result, and there are some great, great studies done by Ed Oldfield in the past. I don't think you could do anymore. These were patients that kind of electively got lumbar punctures or randomized. You can't do those types of studies anymore, but the blockage of flow causes two problems. It causes pressure here and causes pressures here in a very pulsatile fashion. Because as you saw, it changes. That's why symptoms change, because the way your head's positioned, the way the pressure in your head changes throughout the day. When this fluid is trapped on the outside of the spinal cord, it goes into the spinal cord and it causes a cyst. We'll talk a little bit more about that lately, but you have to put all these things in context when you're talking about treatment, and that becomes an important thing for your decision tree of what you're going to treat and what order you're going to treat. So hydrocephalus you absolutely have to rule this out. Anyone who has a Chiari, they need at a minimum a plain CAT scan of their brain to make sure that they don't have hydrocephalus. It's also important to realize that that fluid-filled cavity is going to be very different in a 50-year-old and certainly a 74-year-old than it is in a 25-year-old or a 10-year-old or a 5-year-old. The ventricles are very, very small and slit-like the younger we are, and as we get older, like everything else in our body, it starts to get soft and saggy, and it opens up, and the compliance goes, and it starts to wind. So you have to put into context what's normal for that patient based on age and history. My thought is I generally treat the hydrocephalus first. Why? Just because that's my experience and my bias. I've been burned several times. If you don't treat the hydrocephalus first, in my experience, what's happened to me early on in my career is these patients then continue to have CSF leaks, and they keep coming back because the suture line keeps leaking, and that's because there's an increased pressure. So sometimes you don't know this because there's not an obvious hydrocephalus, especially in younger patients early on. And if you start seeing patients who continually come back with a leak and you have a watertight closure when you're finished, you really have to start looking at hydrocephalus. And that is a subset of patients where we will then go in and put a shunt to take that pressure off of the suture line because they have an underlying hydrocephalus. And I'm not going to get too much into the surgery, but really, when I trained way back in the dark ages, we took the whole back of the skull off. We did suboccipital craniectomies. We opened everything up. I actually had one of the senior faculty that used to stick muscle, and the docs are laughing because they may remember in the OBEX, and they would basically block off the fluid flow because we just didn't understand back then. The opening for a Chiari usually is very small now. It's really focusing on what the pathophysiologic problem is and correcting that, which is this. And this is, I promise, the only surgical slide. And these are the cerebellar tonsils. This is the dura and everything opened up. And this herniation should be up here. I personally shrink these. I will use cautery so that these get shrunken so that they're up here and nice and flat, just so there's that nice big wide open space. And one of the reasons I like it too is because when a patient, let's say, has some type of symptoms maybe 3 or 4 years later, I like coming back and those tonsils are gone, and it's a better feeling of knowing that there's a wide open space there. So let's get into the symptoms. Let's talk a little bit about this. So 70% of patients with Chiari will present with some type of pain. And, pain can be a very, very difficult thing, believe it or not, to diagnose, because if I asked everybody in this room, what they describe as pain, everyone's going to describe something a little bit different. And there's also no gauge that you can put on someone's forehead that says, okay, you're a 6 out of 10. So it's important to dissect out what type of pain it is and the cause of it. So headache is one of the most common, 35%. Now, traditionally, we talk about the occipital headaches, Valsalva, coughing, laughing, sneezing. That's not always the case. The headaches can be different. They're not always occipital. They usually are, but not always. Neck pain, girdle pain, arm, and leg pain in this descending order. I think that's pretty true. Weakness, 56% of the time there'll be weakness. Either weakness that the patient themselves notice or that the doctor will notice on physical exam, particularly for long-standing hand intrinsic weakness is a big one because patients will tend to adapt to that over time. It's, I'm just clumsy and, I drop things. And sometimes a spouse or significant other will pick it up more than even the patient. But that's one of the first things we look at. Numbness and arms, legs, you see in the textbooks the cape-like distribution with syrinx. It's not always the case. As a matter of fact, I think it's, the minority of the time where patients will describe this cape-like distribution. So the numbness can really vary. Loss of temperature sensation. A lot of the patients will come in, they'll have burns. They'll have burns on their hands, and you'll see it, again, over years because they've lost the sensation of temperature in their hands and or feet. Unsteady gait, double vision, difficulty swallowing, ringing in the ear, and then other things, dizzy, fainting, face numbness, things like that. And again, these things all fit in. I've had several patients with hiccups. I didn't do surgery because of the hiccups. I did it for the other symptoms, but the hiccups went away with the surgery. Not common, but it is something to look out for. So signs. So symptoms and signs are different, right? Symptoms are what you feel. Signs are what we're looking for outwardly that are presented. So nystagmus, the eyes beating. When you look up, you can look to the side, but particularly when you look up, the eyes kind of do this quick beating. Difficulty with gait. And, there's no one, in my experience, there's no one particular, that's a Chiari gait. Some things do have that. Parkinson's, normal pressure hydrocephalus. Chiari really varies. And, having a patient walk down the hall and then kind of do that turnaround and then kind of waiting for a wall or something to hold them up, that's something that's commonly seen. I will focus more on a friend, spouse, or significant other when we talk about gait, because I would be willing to bet everyone in this room, think about your significant other or someone that you've been with for a very long time. It can be a family member. You kind of know how people walk, right? So if you're like in a mall or you're in a place like this where there's lots of people and you're looking for someone, you can see the gait of people walk. And everyone has a little bit of a unique walk to them. So significant others, spouses, they usually will be able to say his walking's or her walking's not the same. It's off. This is not, they normally don't do this. They never had problems with, turning around. So I spend a lot of time talking to family members. Sometimes they pick it up more than the patient. Clumsy, frequent falls, keeping in mind, some people are clumsy. That's another thing that's important with those kind of borderline MRIs. I mean, ask that question. I mean, I could play sports. I was clumsy my whole life. I couldn't do this. I couldn't do that. Some people are just clumsy as a baseline. But bumping into a wall, that's usually not normal. That's not normal clumsiness. Hand atrophy, where you can see the muscles in the hand wasting away, particularly if it's, asymmetric, one hand more than the other. Weakness, usually in the arms, but often in the legs. Then we talked about the sensory. So one of the big ones is fatigue, depression, and memory loss. And, a lot of times I'll have patients who rightly get offended where, well, it's stress. It's, you're depressed. It's all in your head. Well, it's not really all in your head. Stress, we have a much better understanding of stress than we did 5 years ago. Stress has a very, very toxic effect to the body, and not just mentally, but physically. It actually will manifest itself physically in people. Everybody. We all have stress. If you don't have stress, you're not a human being, or you're drinking. It's at a cocktail hour, because we all have stress, and it all affects us. But that level of how it affects you and what else is going on in your life is very important. So it's a result of a constellation of other things going on. If you are debilitated with headaches and you cannot function, if you're having problems at work because you have headaches all the time and you're missing work, you're going to get depressed. And when you get depressed, you're going to it's this vicious cycle that goes around. It's very important to kind of dissect that out. And then misdiagnosis makes that even worse, because then you start thinking it is you and you're crazy and it's, all the doctors are telling me I'm fine. You have to dissect all these things out. So education and understanding will reduce and oftentimes completely relieve, that toxic form of stress. And the devil's in the details, understanding headaches. Not all headaches are the same. And I had an eye awakening when we started really getting into more of a comprehensive headache center, because it's one of the things that I've focused on over the years, because we all headaches. Well, it's a specialty unto itself now, a true specialty. And there's over 100 types of headaches, which I didn't know 5 years ago. I was like, okay, there's migraine, there's cluster, all the stuff we know from our exams that we take and things like that. But there's over 100 types of headaches. It's critically important to make the right diagnosis of what type of headache you have so that the treatment is appropriate. And it's not just, either opioids or, there's varying degrees of treatment. Pain is very common, but it almost always fits a pattern. This kind of, I hurt everywhere. That doesn't really fit. You have to localize the pain to what the findings are, what the MRI looks like, and what you're thinking, particularly if you're going to be going for surgery. Because the goal of surgery, right, is that whatever surgery I'm doing, for whatever it is, the symptoms that you're having are related. Because if they're not related, the surgery is not going to take care of those symptoms. So it's very important to make sure that that pattern fits. The weakness is specific. It's not a diffuse weakness, because when you're not sleeping well, when you're depressed, when you're fatigued, that's a different type of weakness than legs being weak and somebody who can't get up steps and continues to trip on things. And if the symptoms don't correlate, a good result is almost always not going to happen. So it's really important to focus on those symptoms. And if surgery doesn't help the diagnosis, if surgery doesn't help, then the diagnosis is usually wrong. And more continued surgeries will cause more problems. There's lots of patients, and there may be some in the thing, that have had 5, 10, 15, 20 surgeries, all related to the same thing. At some point, you have to start thinking, okay, maybe something's not right here. And it's surgery doesn't always help long term, but if surgery doesn't help right from the get-go, that there's not an somewhat immediate effect within the first couple of weeks after surgery, you haven't really alleviated the symptoms, and that means that you have to start questioning the diagnosis. And it sounds simpler than it is, and that, how could the surgeon do this? It's not easy. And just, I'm pulling out some very clear dissecting cases. There's a lot of gray in here. So that's why on both fronts, as a patient, being your own proponent and really making sure that you're kind of going through stepwise with your physician, and from the physician standpoint that we really, really listen to these symptoms and try to correlate them. So facts and thoughts: 30% of patients are asymptomatic, and these are known Chiaris. And we talked about the number of incidental Chiaris out there. No one dies of a Chiari, and sometimes that's a controversial thing to say. Now, there are caveats to that, especially in the pediatric population. And the reason I put this up here is because the first thing that I think is very important is explaining what a Chiari on a model is to a patient, and also alleviating that stress and fear. Because, we forget sometimes that, most people, they don't know what a Chiari is. You're having all these horrible problems. You're usually diagnosed by a primary care doctor, and they're like, well, they found something on your MRI. You need to go see a brain surgeon. Now you're waiting 6 weeks to go see the brain surgeon because you have something on your brain and you have all these symptoms. And So there's a lot of stress that goes with that. And one of the first things I say is, listen, this is a fixable problem. There's a path that we're going to go through. Let's see if you even need surgery. You're not going to wake up and be paralyzed in the morning. You're not going to wake up and, this isn't going to take your life. Surgery is not a trial. It's permanent. Once you commit to surgery, and I'm not talking about from us as a surgeon, I'm talking about you as a patient, that's a permanent thing. That's not like trying a medication, and if you have side effects or it doesn't work, you stop it and you try something else. Once there's surgery, once you cut that skin, there's no going back. So you choose a treatment for the condition, not the individual symptom as well. And the degree of herniation really, and I'm curious to what my colleagues think, but I think we've all seen these horrible, horrible looking MRIs, and the patients really are either asymptomatic or the symptoms are very mild, or a very mild looking Chiari and MRI, and the symptoms are real and they do very well with surgery. So it's important to, it's not a number of like, well, I have 8 millimeters of, I have 6 millimeters. That number I don't really even focus on. It's you either have a Chiari and there's obstruction of flow there or there's not, and your symptoms correlate or they don't. And, try to make it simple. So I want to talk a little bit about Syringomyelia and the relationship of Chiari. So as we talked about before, that blockage of fluid. So this is a cystic-like cavity, that the Chiari, which is CSF in the center of the spinal cord. So normally it should be just this, solid yellow. There's a very, very thin line in here that most times you can't see called the central canal. And the fluid's on the outside. But if the fluid's blocked higher up here, there's nowhere for this fluid to go, so it goes into that central canal and it starts to expand. And this is what it looks like on an MRI, and they can be very, very severe. So one of the conventions, and one of mine used to be, was if there's a syrinx, I always treat. I don't really think that way anymore because I've had a few patients who've kind of changed that, and one of the most dramatic ones is Gia, 64-year-old. She was diagnosed about 12 years ago. She was pretty much asymptomatic. She was having some baseline tingling in her feet. She got an MRI, which I follow her yearly with, and that's her. I'm sorry. This is her. And she refused surgery. I actually recommended surgery to her because of her, symptoms. And I probably still would, to be honest with you, going back. She refused surgery. This was 12 years ago. See her every year. She brings me lemon bread, and she's a Spanish teacher. She's probably one of the most active women I've ever met. The woman's always doing 15 different things. And she's asymptomatic, and I've been following it. So I think, not every syrinx 100% needs to be treated. So let's talk about a different type of syrinx, because this is another thing that brings in a lot of confusion. So here's a 56-year-old gentleman. He had major trauma from an MVA, had the jaws of lice with extricated him. He had multiple spinal fractures about 29 years ago. He's actually had a remarkable recovery. But over the last several years, he's been having this severe burning pain in a band around his chest. So everyone was looking at a lot of different things, and they finally got a MRI of his thoracic spine, and there you can see this is way, way down in his mid-thoracic and his chest. You can see this syrinx that's here, and this is kind of in the center. The gray is the spinal cord and that fluid. You can see that fluid just kind of pushing out the neural tissue. There's not a lot of, this is a different type of syrinx. This is a traumatic syrinx. Surgery's not going to help this. He doesn't really have a Chiari. There's a question of one, and I think it was more the radiologist reading into it because he saw a syrinx. But surgery's not going to help this gentleman. This is more how we treat the neuropathic pain, the pain that's being caused from these fibers being stretched in his thoracic spine that correlate very well. Surgery's not going to do anything. This is a very, very different type of lesion. Chiaris are syrinx are very common with Chiari, but they're usually up in the cervical spine. Sometimes they are lower down, and sometimes they're continuous, and they're what we call skip lesions, where you have a big one up high, normal spinal cord, and then another one further down. You have to rule out a cystic tumor. You can't just assume. So everyone that has a syrinx, I'll get an MRI with contrast to make sure there's no tumor component. Trauma, again, and a lot of times, people will bring up trauma that they forget to tell you about. So it's really important to ask about that. And then other types of things outside of Chiari, like basilar invagination, which I think someone's giving a talk about. And the symptoms with that are usually pain, almost always pain. The classic is a sensory loss with dissociation of pain and temperature with, you can kind of feel somebody touching you, but it's because of where the fibers go, there's a disconnect there. Weakness, especially in the arms and hand, depending on where it is. And again, you can see this is where the cyst is, and you can see why, as it expands out, it's pushing on those fibers in the center of the spinal cord. So I'm going to 5 minutes left here. So, you know, my advice is a kind of what I give to my patients is, you know, first of all, you're the only proponent. You are going to be your proponent, and always keep that in mind. Don't be afraid to ask questions. Don't be afraid to, you know, I think there's this idea in the old days of doctors going, oh, when you say I was on the internet. I think most doctors will tell you, I don't mind people going on the internet. As a matter of fact, in a lot of ways it helps because, you know, we can start off right on the same page. The trick is making sure that you understand the source and that you work with your doctor to kind of go through what's specific to you and your issues. But you're your only proponent. If you're hearing something that doesn't make sense, if someone's not explaining something to you, or they're getting frustrated, or they're getting short, then you know what? You have to take care of you. Speak up. Make your doctor explain everything to you. You know, your doctor should always be saying, does that make sense? Are we on the same page? And because a lot of times it'll be this, and especially there's a difference in age. I think the older patients, you know, my parents' generation were very much, well, the doctor knows. He said this, so you have to kind of keep that in mind too. My older patients, I really want them to know that, you know, they need to be asking me questions because there may be something that they don't understand, and I'm assuming they do. Get a second opinion. A second opinion is not a bad thing. I tell all my patients to get a second opinion. Any doctor that gets worried about you seeing a second opinion, run. And I think I can speak for all my colleagues here. The internet, again, is not a bad thing, but it's only as good as the source. You have to be very careful of what's in there. And it's a general statement, even in the best things. If you go to NIH and every hospital has their own thing, you know, you have to be able to put in context what's on that internet page to you, because as we've seen, there's a lot of caveats. So my treatment paradigm is always symptoms first, patient exam, and then MRI. You know, the MRI is kind of the second thing. If the symptoms don't correlate, you know, the MRI, you know, short of something dramatic, is secondary. Patients that have really early symptoms are very mild. I'll usually follow them and see the pattern of their disease. And you know, I've been surprised over the years. A lot of times the symptoms go away, or they just kind of stabilize. And again, we're talking mild symptoms. Again, you know, it's important if you're going to take that route that you don't just send patients off and say, well, call me if you see problems. There has to be a plan. I'm going to see you back in 3 months. I'm going to see you back in 6 months. We're going to repeat an MRI. And, you know, I always tell them, look, you're not going to, I promise you, you're not going to wake up paralyzed. You're not going to wake up and not be able to move from the neck down. You know, this is something that we're going to follow. This is a chronic condition. You know, if there's no symptoms and the signs don't correlate, I cannot do surgery, because the goal of surgery is to alleviate those symptoms. So it really is important to correlate those two. One of my triggers is weakness, is actual real motor weakness, particularly in the hand intrinsic. I find that is a very good correlation and prognostic indicator. So in conclusion, the symptoms of Chiari are multifocal. There's no one size fits all. MRI findings don't always correlate with the clinical symptoms, both on the degree of herniation and some of the other findings, including Syrinx. Chiari is treatable and curable, but the right patient choice is essential. You know, again, as a positive sign, you know, I tell my patients, this isn't cancer. This isn't something, you know, that is on that spectrum. This is something that we can treat and potentially cure, and oftentimes can. You know, once the surgery's done and patient's symptoms go away, you know, the Chiari's gone. And I personally, I don't give my patients any restrictions. They can go on roller coasters, they can lift, they can do whatever they want, because that pathophysiologic problem is anatomically corrected. Again, be vocal and be your strongest advocate. And that's it. Thank you. Right on time.